Mrs. Peterson, a 65-year-old retired librarian, was on her 8th day of clindamycin therapy for cellulitis when she began experiencing severe watery diarrhea, abdominal cramping, and fatigue. She initially dismissed the symptoms, attributing them to dietary changes. However, as the diarrhea worsened, she noticed signs of dehydration and sought medical attention at the hospital. Dr. Carter, the attending physician, listened attentively as Mrs. Peterson described her symptoms. Concerned, he noted that Mrs. Peterson's age and recent antibiotic use placed her at high risk for Clostridioides difficile infection, a common complication of disrupted gut flora caused by broad-spectrum antibiotics like clindamycin. Dr. Carter conducted a thorough assessment. Blood work revealed a white blood cell count of 16,500 per microliter and a serum creatinine level of 1.8 milligrams per deciliter, suggesting severe CDI. Stool testing confirmed the presence of C. difficile toxin, solidifying the diagnosis. This infection results from gut flora disruption, Dr. Carter explained. The bacteria produce toxins that can cause colitis, leading to severe diarrhea and dehydration. An important first step was discontinuing clindamycin, the antibiotic associated with Mrs. Peterson's CDI. However, since her cellulitis required ongoing treatment, Dr. Carter selected doxycycline, an antibiotic rarely associated with CDI, as a safer alternative. Dr. Carter initiated oral vancomycin therapy, reconstituting the powder for oral administration since oral formulations were unavailable. He explained, "This approach ensures the medication targets the infection in your intestines while reducing systemic effects." To improve taste, the pharmacy added a flavoring syrup to the solution. Supportive care included intravenous fluids to correct dehydration and electrolyte imbalances. Dr. Carter emphasized the importance of hydration, as CDI can lead to significant fluid losses. Over the next 48 hours, Mrs. Peterson showed signs of improvement. Her diarrhea began to subside, and her energy levels improved. Dr. Carter explained the importance of completing the 10-day course of vancomycin. He also reassured Mrs. Peterson that repeat stool assays would not be necessary after treatment, as positive results can persist even after symptoms resolve. The lesson. Dr. Carter gathered his team to discuss the case. Acute diarrhea, greater than or equal to 3 loose stools in 24 hours, with a positive stool assay, is diagnostic when no other explanation exists. Severity is assessed using WBC and serum creatinine levels. Discontinuation of the inciting antibiotic, as clindamycin, is a key step. If ongoing antibiotics are necessary, select those less likely to cause CDI, such as doxycycline. Oral vancomycin or fidaxomicin is the first-line treatment. Reconstituted vancomycin powder can be used orally in resource-limited settings. Addressing fluid and electrolyte imbalances is critical to recovery. Dr. Carter concluded, Mrs. Peterson's case highlights the importance of precision in managing antibiotics and addressing complications. Every decision must balance treatment efficacy with the risk of adverse effects.